Hello, this is Dr. Marty Lofka. I'm the Internal Medicine Clerkship Director at SIU School of Medicine, and this is the first in a series of 3 videos that are a workshop on the basic approach to interpretation of electrocardiograms. The target audience for this workshop are 3rd and 4th year medical students, as well as PGY1 interns. The assumptions for these videos are that the learner will have knowledge of the heart anatomy and the conduction pathway, knowledge of rudimentary electrocardiography, knowledge of heart pathophysiology, knowledge of common arrhythmias, and knowledge of AV nodal blocks. These videos are designed to be pre-work for a workshop that will be available to students rotating through the internal medicine clerkship. Throughout these videos, I'm going to hopefully answer some common questions that often pop up from students and PGY1 residents in terms of interpretation of ECGs and misconceptions about what they're looking at. So we are going to review the electrical anatomy of the heart, and we're going to show how that relates to what we see on an ECG. We're going to talk about a basic systematic method for interpretation of ECGs, and we're going to prepare to practice reading ECGs in our in-person workshop. This session's not designed to teach you everything. It's just a place to start, and hopefully is a place where some of your misconceptions and questions can be answered ahead of time. So let's think about what resources do you use. Many learners rely on online resources for learning to interpret ECGs. There's nothing wrong with that. There's some really great resources out there online. The ECG Academy and Life in the Fast Lane are 2 very good ones. And other learners like to utilize textbooks for helping to learn ECGs. Also, there are some great resources, book resources out there for learning ECGs. I think that a combination of the 2 is reasonable as well, because in order to learn to interpret ECGs, you have to practice. As with any clinical skill, you have to practice in order to get better. Interpretation of ECGs is not something that you can cram before the exam and truly understand. So I would encourage you to look at resources, potentially obtaining resources where you have lots of practice ECGs that you can practice your skills with. So let's talk about what we're looking at on an ECG. So we are following the basic conduction pathway of the heart. And so at this point in your education, you should be well aware of the electrical system of the heart with the SA node, the AV node, the bundle of His, and then the bundle branches. So the bundle of His splits into a right and left bundle branch, and the left bundle branch further splits into the left anterior fascicle and the left posterior fascicle. And why is this important when we're talking about ECGs? Well, obviously, ECGs are looking at the electrical pathway of the heart. And you can see abnormalities in any one of these components of the electrical pathway on the ECG. It's important to know the normal rates of automaticity for the different foci of electrical activity within the heart. So the normal automaticity of the sinus node is 60 to 80 beats per minute. We do recognize that normal heart rate is 60 to 100 beats per minute, but typically the sinus node for a person at rest is going to run between 60 to 80 beats per minute. Ectopic atrial foci will have a similar rate of automaticity. Junctional foci will run about 40 to 60 beats per minute. The junction is another term for the area around the AV node. So it's often called the AV nodal junction or the AV junction. And so if you hear the term junction, that's what that means. And then ventricular foci will run about 20 to 40 beats per minute. Here we see the ECG of normal sinus rhythm, and you all should be very well aware of what we're looking at. We see the P wave, we see the QRS complex, and we see the T wave. And this diagram also indicates where the intervals are measured on an ECG. So you can see that the PR interval is measured from the beginning of the P wave to the very beginning of the QRS complex. The QRS complex interval is measured from the first deflection to the J point, which is the end of the last deflection in the QRS complex. And then the ST segment is the very end point of the QRS complex to the very beginning of the T wave. The QT interval is measured from the beginning of the QRS complex to the very end of the T wave. One common question that pops up, or misconception that pops up with students, is about the naming of the QRS complex, which wave is which. And so I've had questions about this before. So it's important to recognize that in the QRS complex, that some students often have the misconception that the very first deflection, no matter which direction the electrical activity is going, is called a Q wave. That is incorrect. So a Q wave is always negative, meaning it is below the baseline. So if the first deflection of a QRS complex is negative, then yes, that is a Q wave. The R wave is always the positive portion of the QRS complex. And then the S wave is always negative. And this doesn't matter which lead you're looking in. This is always the case in the naming of the QRS complex. So Q is always negative, R is always positive, S is always negative. And this becomes important later on when we're taking a look at bundle branch blocks and naming waves within the QRS complex. As everyone should be aware, the P wave is associated with atrial depolarization, the QRS complex is ventricular depolarization, and the T wave is repolarization of the ventricles. In order to recognize abnormalities in an ECG, we have to know what's normal. So it's really important to understand what the normal length of interval is on the ECG for each of these segments in order to identify abnormal intervals. So you should commit to memory what the normal intervals are. So a normal PR interval is 120 milliseconds to 200 milliseconds. This equates to 3 small boxes to 5 small boxes on an ECG grid. The QRS interval is normally less than 120 milliseconds, which equates to 3 small boxes. The normal QT interval is dependent upon heart rate, and so therefore it has to be corrected for heart rate. The normal QT corrected is less than 430 milliseconds. This is the one calculation that's on an ECG that I will allow the computer to do for me, just because the calculation is fairly tedious. And so this is the one piece of information that I will rely on the computer for on an ECG. Everything else I read myself. Okay, so on a 12-lead ECG, 6 of the leads are considered limb leads and the other 6 are chest leads. So you see the limb leads and the placement of those leads on the left. So you have leads 1, 2, 3, and then their perpendiculars are AVR, AVL, and AVF. The chest leads are V1, V2, V3, V4, V5, and V6. And you can see the placement of those leads on the patient on the chest diagram on the right. every 12-lead ECG is laid out in the same pattern. So if you take a look at the graphic on this slide, you'll notice that the limb leads are all on the left-hand side. So leads 1, 2, and 3. Next column is AVR, AVL, and AVF. And then the precordial leads are on the right. So the next column over is V1, V2, V3, followed by the last column, which is V4, V5, and V6. Every single 12-lead ECG is going to be laid out in this same pattern. This becomes important because there may be some older ECGs that you'll see as an example where the leads are not labeled. And so it's important to know where to find each one of these leads on a 12-lead ECG. The other thing to note here is that the leads correspond to the heart anatomy. So if you're looking at this graphic, you notice that leads 1, AVL, V5, and V6 are all shown in green, and they're all associated with the lateral portion of the heart. And so they're called the lateral leads. These leads typically correspond to the left circumflex coronary artery. So if we had a patient who was having an ST elevation MI due to a occlusion of the left circumflex, we would expect to see ST elevations in leads 1, AVL, V5, and V6. Leads 2, 3, and AVF, shown here in yellow, are also called the inferior leads. The inferior leads correspond to the inferior portion of the heart, which is typically the right ventricle, and it is associated with the right coronary artery. Leads V1, V2, V3, and V4 all correspond with the left anterior descending artery. V1 and V2 is associated with the septal portion of the LAD, and V3 and V4 are associated with the anterior portion or the anterior territory of the heart, which is typically supplied by the LAD. You'll notice that AVR is kind of off by itself and not really labeled. AVR, for the most part, is the forgotten lead or considered a throwaway lead. For our purposes, that's probably true. There is some information that can be gleaned from an AVR. It's typically cardiologists who are interested in what they can see in AVR. It can help to identify an area that may be the source of a lesion for an MI that's in an area that's not typical, or it could also be utilized to help identify an area where an arrhythmia may be generated. So an electrophysiologist may have some interest in what's happening in AVR. For us, we still consider it kind of a throwaway lead at our level of learning for the ECG. So just kind of wanted to give you guys a little bit of a heads up about why we don't really look at it, but why it still is an important lead for some of our cardiology colleagues. So let's talk about a few quick points before starting. On every 12-lead ECG, the grid has small boxes, and then 5 small boxes equates to 1 big box. A big box has a more bold border than the small boxes. The y-axis is voltage, the x-axis is time. Each small box equates to 40 milliseconds in time. And each big box, therefore, which is 5 small boxes, is 200 milliseconds in time. I'd also like to clear up a misconception that I frequently encounter with students when we first start reading ECGs together, is which beats correspond to which beats over the course of the ECG tracing as we move from lead to lead. Many students will often ask whether or not the first beat in each lead corresponds to each other. So you can see as I'm marking across lead 3, AVF, V3, and V6, some students have the misconception that each one of those those tracings corresponds to the exact same beat. No, that is not the case. So what we're seeing in a 12-lead ECG is that we are seeing 10 seconds in time. And so you can see the top 3 lines of tracing are the 12 leads that we've discussed before. And so they're labeled, as we had mentioned before, 1, 2, 3, ABR, ABL, ABF, V1 through V6 in the 4 columns. But they are all happening across the ECG, which is 10 seconds in time. So that bottom tracing that you see is lead 2 for the entire 10 seconds of the ECG tracing. And so the beats that actually correspond to each other. So if we take a look at the first beat with lead 2, this beat corresponds with this beat, and this beat in leads 1, 2, and 3. And so if I were to move down the line and choose another beat with lead 2, that beat that I'm marking in blue again corresponds with the beat directly above it, corresponds with the beat directly above that, and so forth in leads V1, V2, and V3. Okay, getting started. When you're presented with an ECG, the first thing you need to do is make sure it's for the right person at the right time. If you can find an old ECG to compare with a new ECG, that can be really helpful, because if you see something new that has developed from the past to the current ECG, that can help in trying to diagnose what may be going on with the patient. I cannot emphasize enough that you need to read the ECG yourself. Do not rely on the computer reading. It's often wrong, especially when it comes to rhythm assessments. You have to read it yourself. And you want to make sure that you're reading an ECG with the same systematic approach every single time, because if you're not using a systematic approach, you're going to miss something, especially as you're just learning how to read ECGs. And you may miss something big if you're just kind of glancing over it and not using a systematic method. So what is the systematic approach that we utilize? It's pretty much the same, any resource that you're looking at. We look at rate, we look at rhythm, we look at the axis, and then, we look at the intervals and the morphology of the waves. So the intervals in morphology of the P waves, the PR interval, QRS interval, QT interval. We evaluate the ST segments. We look at the morphology of the T waves, and we look for U waves, which are pretty rare, but they do occur. We're also looking for evidence of ischemia and infarction. I will talk about them as this is a separate topic, but often when I'm looking at the morphology of the QRS complex, looking for pathologic Q waves, looking at the ST segments, I'm doing all of those things together, but that's also because I am practiced at it, and so that's become part of my process. And the last thing that we look at is to see whether or not there's any evidence of hypertrophy, right ventricular hypertrophy or left ventricular hypertrophy. So the first step in our systematic method is to determine rate, heart rate. And so there's a couple of different ways that we can potentially do this. Many of you have probably run across the rule of 300, which is demonstrated by the graphic in front of you. And so that rule of 300 is that if you were to take the R to R interval, meaning the distance between one QRS complex and the next QRS complex, which is also called the R to R interval, and you're taking the number of big boxes, you're going to divide 300 by the number of big boxes between those QRS complexes. And so you can basically memorize the sequence. So I frequently utilize this process. So it's 300, 150, 100, 75, 60, 50, 43. That's usually where I no longer remember that 37 is the next step. because by then I know that my heart rate is really slow. We have bradycardia for some reason. You know, you can use the rule of 300 only if the rhythm is regular. So if the rhythm is irregular, obviously this is not going to work because your R to R interval is going to vary if you have an irregular rhythm. And so in the case of an irregular rhythm, there's something called the rule of 6. And so thinking about a 12 lead ECG being 10 seconds in time, it's 10 seconds across. You can count the number of QRS complexes in the ECG, then multiply that by 6, and that gets you your heart rate. If you have a telemetry strip, if you guys have seen a telemetry strip, it's basically a long piece of paper with a single lead tracing on it. You can count the number of QRS complexes within 30 large boxes. That's actually 6 seconds in time, and you can multiply that by 10. I don't frequently have the need to do that because telemetry, for the most part, is computerized now, so you don't really need to print out strips to determine heart rate. But if you ever need to do that in a pinch, now you know how to do it. Okay, so let's take a look at this EKG and try to determine the rate. So at a first glance, I am noticing that the rhythm looks regular to me. So if I were to measure the R to R intervals between each QRS complex, they are going to be about the same distance. And so since this is a regular rhythm, I can use the rule of 300. And so I'm going to look for a QRS complex that is sitting as close to one of the bold lines or the large boxes border that I can find. And so the closest one that I can find is this one right here. And so I'm going to start there, and then I'm going to use that rote 300 memorization, rule of 300 memorization. So 300, 150, 100, 75, 60. And so this QRS complex is somewhere between 60 and 50. And so I'm going to say it's about 55 or so beats per minute. So it's a little bit bradycardic, but it's a regular rhythm. And so therefore I can do that rote memorization rule of 300. Moving on to this EKG, it clearly is not regular. So if I'm looking at the rhythm strip at the bottom, and in this EKG, the rhythm strip is lead V1, this clearly is not regular. And so how do I know that? If I'm looking at the R to R intervals between beats, if I were to measure this R to R interval, I'm going to call this R to R1. It is clearly longer than the next R to R interval. I'm going to call this R to R2. So when I think about irregular rhythms, the other thing that we need to decide is whether or not an irregular rhythm has a pattern to it or whether it is completely chaotic and there's no pattern. And so if there is a pattern to the irregularity, that is called a regularly irregular rhythm. And so in this EKG, there is clearly a pattern to it. Because if I were to measure the R to R intervals between each beat, there would be a consistent distance between R to R intervals going back and forth. So this one is going to match up with R to R1. The next measured R to R matches up with R to R2, and so on. So this is a regularly irregular rhythm. But since it's irregular, I know I can't use the rule of 300. And so what am I going to do? I know I've got 10 seconds in time across the ECG, and I'm going to measure, or I'm going to count QRS complexes. So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 times 6 is 54. It's probably between 54 and 60. So about the same heart rate as the previous one. A little bit bradycardic, but not really remarkably bradycardic. All right, so that's the end of this video. We have had an opportunity to review the electrical anatomy of the heart. We've had an opportunity to take a look at the 12 different leads in a 12-lead ECG. We've reviewed how those leads are laid out in a 12-lead ECG and what leads correspond to what coronary artery. We've also talked about the normal interval lengths for the PR interval, QRS interval, and the QT segments. And we've practiced determining rate. And so the next step for you are to make sure you know the normal rates for automaticity foci, know the normal interval length for the PR, QRS, and QT segments. Memorize the lead layout of a 12-lead ECG. And then you should practice determining rate by both the rule of 300 and the rule of 6 on some practice EKGs. You should understand in which situations they can be used. When you're ready, move on to the next video, which is Basic ECG Part 2. See you there.